So the topic which I have been allotted is pioneering oral GLP-1 receptor analog in cardiovascular risk management. So the benefits beyond glycemic control. So thank you very much for giving me this platform to deliver the talk. The financial disclosure, yes, this program is sponsored, so I do have financial disclosure. Now, my agenda is cardiovascular mechanisms of oral semaglutide, how it works, what are the things it does apart from lowering the HbA1c. Then I'll briefly talk upon the pleiotropic effects of oral semaglutide and its benefit across type 2 diabetes spectrum. And then I briefly summarize whatever I deliver today. So coming to the cardiovascular mechanism of oral semaglutide. Now, as we all know, there cannot be a single mechanism because, yes, the predominant mechanism obviously will be to reduce HbA1c, but apart from that, it affects in the insulin resistance. So, insulin resistance, as we all know, is very important pathophysiological, mechanism of type 2 diabetes management, and then it also reduces body weight. While doing so, it also reduces inflammation. I'll show the data from various trials, how it reduces inflammation, what are the evidence. Lipid parameters are also improved. Say, for example, the triglyceride component as well as VLDL component is reduced, and there is also effect on LDL. There is direct effect on the myocardium and endothelial function, which is very important, particularly for the development of atherosclerosis process. And as we all know, it has some effect on the blood pressure. On an average, across the different trial, it has shown to reduce blood pressure to the tune of 5 millimeters systolic blood pressure with the dose of 14 milligram per day. So that is quite a significant reduction of blood pressure. And there is also reduction of hyper and hypoglycemia. So basically, the molecule works by increasing the insulin secretion from the beta cell, also by suppressing the glucagon. But very interestingly, it never produces any hypoglycemia because the insulin secretion, whatever happens, is basically, it is quite nicely related to the food. So in fed state, it increases the insulin secretion. In other empty stomach, it actually do not increase the insulin secretion. So with this particular molecule, there is no issue of hypoglycemia, which is very, very important and relevant for cardiologists like us, because we do not favor molecule which causes hypoglycemia. Because as you all know, hypoglycemia, during the spells of hypoglycemia, many autonomic dysfunction actually takes place, and this autonomic dysfunction can actually lead to some fatal arrhythmia. And some of these arrhythmia, if say for example ventricular tachycardia or ventricular fibrillation, can actually lead to sudden cardiac death. So being a cardiologist, I am very, very fearful about the hypoglycemic spell. So I always choose molecules which do not come with hypoglycemic effect. So this molecule, though it actually works through the insulin, but it never produces hypoglycemia. So that is one of the very fantastic benefit of this molecule. Now, all this mechanism, insulin, reduction of insulin resistance, reduction of body weight, inflammation, improving the lipid metabolism, and the direct effect on the myocardium, improvement of the endothelial function, blood pressure reduction, and the hypoglycemia reduction or hyperglycemia reduction actually leads to anti-atherosclerotic effect. So this anti-atherosclerotic effect, which is actually the main problem with long-term diabetes. As we all know, diabetes accelerates the atherosclerosis process. So by using this molecule with this different mechanism, the anti-atherosclerotic effects are seen, and that leads to cardioprotection and all the CV benefits, which has been seen across different GLP-1 analog trial. So as a result, we can see various effects. We can measure them. Cardiac output improves, cardiac contractility improves, endothelial function, it improves heart rate, and ischemic tolerance also improves. Plaque stability, there has been animal study which shows that plaque regression is also possible with this molecule. I'll briefly touch upon them. So anti-atherosclerotic mechanism of GLP-1 analog, yes, it has a direct anti-proliferative effect, which is important. It has been evidence from it has been evaluated in animal study. It also has directly effect on an endothelial dysfunction. It improves it. There is a more production of nitric oxide, reduction of ROS, that is reactive oxygen species, and by that it actually reduces inflammation. Now in gut, it also reduces free fatty acid secretion. So by that also there is some effect. And very importantly, in brain, as you all know, it suppresses the appetite. So the body weight comes down. So as a result, there is reduction of atherosclerotic plaque burden, plaque volume. In animal study, it has been evaluated and found to be very, very effective. These effects are actually beyond glycemic control in diabetes patient, and they address the cardiovascular risk with atherosclerotic cardiovascular disease risk modification with direct and indirect effect. Now, these are the different clinical trials. My previous speaker has already very nicely elaborated it. So Pioneer 1, from starting from Pioneer 1, which was actually with placebo, followed by Pioneer 2, 3T2 inhibitor, DPP4 inhibitor, and Pioneer 6 is the cardiovascular outcome trial, though it was a non-inferiority trial. So it met its primary endpoint. And very important, SOUL trial, which is actually designed for superiority, is undergoing. And in this SOUL trial, there is around 800 Indian participants, which is very important. So we will have very good representation of our own population, how they actually fare. Now, how much reduction of HbA1c is seen with this molecule? In different Pioneer trial, we can see around 1.5% of HbA1c reduction. So it is a very, very potent anti-diabetic molecule in terms of at the end of the treatment. If we see different Pioneer trials, Pioneer group of trials, so we'll find around 5 kg of weight reduction. So 5 kg weight reduction is very important. Now, I just want to mention one very important point when we compare this molecule with SGLT2 inhibitor, which are also very important molecule for weight reduction and favored by cardiologists because of its fantastic effect on the heart failure. But in our experience, we have seen the initial reduction of weight with a SGLT2 inhibitor is very profound, but later on the patient actually catches up. The weight actually goes up in long run. Whereas if we use this GLP-1 receptor analog, the persistence of weight reduction is actually better than SGLT2 inhibitor. So that is a very important difference between the weight reduction of SGLT2 inhibitor and GLP-1 analog. Now, if we talk about the Pioneer 6, which was the non-inferiority cardiovascular outcome trial, so primary endpoint, which was composite of 3 individual endpoints, the non-fatal MI, non-fatal stroke, and cardiovascular mortality, the primary endpoint was actually reduced, less than 0.0001. So it was statistically significant in terms of non-inferiority. So we can see in placebo arm, there was 76 events which was observed, and in the semaglutide, oral semaglutide arm, 61 events were observed. But the p-value for superiority was not met. That is why the next trial was designed. So there was 21% non-significant risk reduction compared to placebo. This is in terms of primary endpoint. Now, if we talk about the individual components of the primary endpoint, the first non-fatal stroke, there was significant reduction with a hazard ratio of 0.74. So there was 36% reduction of non-fatal stroke, first non-fatal stroke. The cardiovascular mortality reduction was also very, very significant. We can see the hazard ratio of 0.49. So there was 51% relative risk reduction of cardiovascular mortality. But one thing which was actually catching the eye is the first non-fatal myocardial infarction. So there was no reduction of first non-fatal myocardial infarction. This is somehow different. In all the GLP-1 analog, they are actually very strong. They are actually proposed as very strong anti-atherosclerotic drug, but even with that fact, the first non-fatal MI was not reduced. This is the fact which we observed in this Pioneer 6. Yeah, definitely this is going to be cleared up in further and subsequent trials, but it was if we look at the hazard ratio, so it is 1.18. So mean of hazard ratio was more than 1. So that is how it is, but there was very importantly, reduction of cardiovascular mortality. 50% cardiovascular mortality reduction is not a matter of joke. And not only that, all-cause mortality was also reduced to the tune of 50% compared to placebo if we use as oral semaglutide. So all this data, though even if the fact that this trial was a non-inferiority trial, but this fact that they have very important reduction of mortality actually boosts up our confidence in this molecule. And this is something new I'll show. This is the pooled data. So pooled data of both Pioneer 6 and Sustain 6, as we all know, injectable as well as oral semaglutide. So both, if we take all the data of semaglutide, be it oral or injectable, then we analyze, we'll find that individual trial data and post hoc combined analysis, it is showing that cardiovascular event as a whole, cardiovascular mortality was significantly reduced. Though the non-fatal myocardial infarction, if we take as a whole with injectable and oral, we can see the hazard ratio is actually less than 1. So there was some reduction to the tune of 12% relative risk reduction if we combine injectable and oral semaglutide, but with oral, actually the hazard ratio goes up. Similarly, non-fatal stroke, there was fantastic reduction overall. 35% relative risk reduction of non-fatal stroke. I'll briefly touch upon why this thing happens. So what is the mechanism of reduction of stroke? So as a whole, the incidence rates of major adverse cardiovascular events were 3.1 and 4.2 events per 100 subject year with semaglutide and placebo respectively, with 24% reduction in the 3-point MACE. So this is, very, very encouraging data. So if we combine both injectable as well as oral data. Now, this is the post-hoc exploratory subgroup analysis of Sustain 6 and Pioneer 6 patients on metformin versus no metformin. We can see whether the patient is on metformin or not on metformin, the benefit actually is similar. This is rather a little more important because if we compare this with the SGLT2 data, then we'll find if we combine SGLT2 inhibitor with metformin, the cardiovascular protective effects actually comes down. How it happens, I'm not sure, but some evidence is there which tells us, whereas no such thing actually is seen with this oral or injectable semaglutide, which is rather very, very important finding. Now, if we summarize the cardiovascular safety of oral semaglutide, so when oral semaglutide is added to standard of care, there is 21% relative risk reduction of overall MACE, 51% cardiovascular death reduction, and all-cause mortality reduction of 49%. HbA1c reduction was very good, around 1.5%. Body weight reduction was also very good, around 5 kilo versus placebo. And overall adverse effect profile was consistent with other GLP-1 receptor analog class. So I already mentioned that non-fatal stroke reduction was seen both with oral as well as injectable semaglutide. So there are now proposed molecular mechanisms for it, because we can see what are the possible mechanisms during stroke. So what it does, it has a very nice effect on the reduction of inflammation, endothelial leakage, which can be important in this kind of stroke situation, and excitotoxicity. At the same time, there is the reduction in the reactive oxygen species production. So neuronal regeneration, apoptosis actually is helped, and impact on the cognitive function of outcome and increased cerebral flow is also seen. So these are different possible mechanisms by which this group of molecule has very favorable effect on reduction of stroke. So semaglutide reduces the incidence of stroke, and the cumulative incidence of stroke over time is significantly reduced to the tune of 32%. So that is very, very encouraging finding. Now, as I mentioned, I'll briefly discuss upon the pleiotropic effect of oral semaglutide now and its benefit across type 2 diabetes mellitus. So first and foremost is the systemic inflammation, because now we know atherosclerosis and inflammation are very, very closely related. So if we see the different data, say for example, Pioneer 1, Pioneer 2, we can find that there is inflammatory markers such as hsCRP was markedly reduced with use of oral semaglutide. And not only that, I already mentioned in my talk, lipid parameters was very, very favorably improved. We can see decrease in the postprandial lipid, say for example, triglyceride and VLDL, as well as ApoB. So these are the lipid we should nowadays look in postprandial state. So lipid profile in fed state are ideal to see for exact triglyceride level. And all these parameters were very nicely reduced with oral semaglutide. And fasting lipid profile, the LDL and all other things were also very significantly reduced with use of oral semaglutide. There was effect on blood pressure, I already mentioned, around 5 millimeter reduction of the systolic blood pressure was observed across the globe. The plaque lesion development, LDL receptor deficient mice, we can see this is the animal study which shows that there is definite proof of plaque lesion regression or plaque regression with use of oral semaglutide. So that's how I think I am almost at the last part of my presentation. If I summarize, in summary, the deciphering mechanisms for pleiotropic effects of this oral semaglutide, we have some targets, some intermediate effects, and the final effects. So insulin secretion, though it is considered to be most important mechanism of this molecule, then comes the glucagon suppression. Natriuresis and diuresis also are important. Appetite suppression is very useful for reduction of body weight. And there is some pleiotropic effect by which cell survival are actually improved. So if we look at the intermediate effect, we'll find that inflammation is significantly reduced as evidenced by reduction of hsCRP in different trials. Coagulation parameters are improved. Postprandial lipids are improved. LV function, myocardial effect, direct effect on the myocardium. LV function has been shown to be improving. B cell survival as well as function are improved, and there is potential neuroprotective mechanism. So as a result, final effect, if we look at the final effect, the reduction of HbA1c, which is to the tune of 1.5%, 5 kg reduction of body weight, blood pressure reduction to the tune of 5 millimeter systolic blood pressure, definite reduction of cardiovascular event, albuminuria reduction, as well as hepatic injury improvement. So all these things are actually final effect as a whole, which give rise to so fabulous and fantastic effect on the cardiovascular protection. So with that, I'd like to finish here. Thank you very much for hearing me.
Thank you, Arindam. Mithun is there. I would ask Dr. Deballo Sannal, Riddhish, and Dr. Ajay Bishwas to share their screens, please. We can have a 5-minute discussion before we close the. Dr. Sannal, yeah, thank you for being there. Dr. Bishwas,
yeah,
Riddhish,
yeah, excellent talk, Arindam.
Thank you, sir.
The only one question is, would you prefer using this molecule in a patient as per current data in patients with established cardiovascular disease or as a primary prevention?
There is a question in similar lines. Just let me add this question to you. Someone with high cardiovascular risk on liraglutide or dulaglutide, would you prefer to switch on to oral sema just due to patient preference? Or if the patient doesn't complain about anything, would you consider?
So there is two ways of looking into it. Already I have done it in one of my patient, every time he used to visit me, he used to say very single thing that I want to get rid of this injection. Doctor, please help me. And I actually told him, because sema took long time to arrive in the market. So I was giving him this hope for last 1 year around. And whenever it was available, first thing I did, I actually shifted the patient from this Victoza to oral semaglutide. He is happy now, though the price, I think, is little higher. Now, if we talk it in terms of science, we'll see the Pioneer 6 actually, in terms of non-fatal cardiovascular, non-fatal myocardial infarction, there is no reduction. Though overall 3-point MACE reduction was there. And very interestingly, cardiovascular mortality reduction was there. Now, if we see it as a whole, that how it is possible, the molecule actually, it is supposed to act against atherosclerosis, how the non-fatal MI can increase, whereas in other trials, other animal study, we have seen the coagulation parameters are also favorably improved. So it is, to be honest, I'm not very sure why the data is like that. Probably because of that, the whole trials have been, developed. It has been framed. It will give us further information. It will clear many of the other doubts. But as of now, we do have evidence in terms of non-inferiority. So non-inferiority, if we take that evidence, I think we can safely, shift the molecule of injectable to oral one if patient actually is not willing to continue injectable. Otherwise, if the patient is happy, I'll still prefer to continue injectable.
Mithun, one question to you, Dr. Mithun. Can semaglutide address glycemic variability?
Yeah,
And
so
I would ask Dr. Sharnal to chip in also.
Okay, so GLP-1 as a class of molecule have done enough CGMSs, and I'm sure Soumya Batada has done a lot of CGMS studies. It's a beautiful molecule which the class itself reduces glycemic variability. Now, oral semaglutide, I'm sure will be not much of different. The new time in range concept, I would say, is the nice wine, old wine in new bottling that we always wanted, that we don't want hyperglycemia or we don't want hypoglycemia. More data, our own data will come out very soon, I'm sure, but I'm sure it reduces glycemic variability, and that itself stabilizes a lot of things, because glycemic invariability causes a lot of problems. And I would just add to Dr. Arindam on the first question is, I would agree with him. I would not rock anybody's boat if they, not try to repair anything if it's not broken. I offered to somebody who was on Victoza 1.9 and he said, "Sir, আমার তো সব ভালো আছে, আমি কেউ চেঞ্জ করবে?" ঠিক আছে বাবা। So you have to actually have a real valid point, which we leave it to patient choice for the time being till the sole data comes out.
Dr. Sharnal, the question goes to you. And to the, I'll come back to the others also. There has been a meta-analysis from Dr. Mohan and his group, which compared the Asian data with the Caucasian data. And he showed that SGLT2 inhibitors have a huge benefit in the trials that he chose in the Asian population in compared to the Caucasian population. And well, the benefit was not that much, perhaps. It was more in favor of the Caucasians when they looked at the GLP-1 data. Although in our real world evidence, you would agree, you were a co-author with me, we have seen that all the parameters were reduced much more higher in the Indian population in comparison to the A population. In Pioneer also, they have showed that Asian population, the reduction is more. Now you have empagliflozin, which reduces cardiac death. And you also have semaglutide. The primary reports say that it reduces cardiac death. Tomorrow being the local elections, so today I would like a vote from you. In which class of patients you would go for EMPA, which class you would go for SEMA, and I would go back to the other two panelists again.
Well, again, probably early on in the spectrum of diabetes, especially in recently detected diabetes in high-risk patients, and early on, definitely to prevent the atherosclerotic process and, the endpoint mortality. Obviously, semaglutide would be the choice. One important thing now we have with regards to GLP-1 is the fact that previously, when we tried to use a GLP-1, because it was injectable, most of the patients wouldn't accept it because of an injectable agent to be used early on, right after metformin. So that was the problem. So the acceptance of early use of GLP-1 was very limited. But out here, if the patients can afford, we can actually start these agents early on to prevent cardiovascular death and all-cause mortality, and probably MACE. As you can see, there's a benefit, especially the pool data, if you look at the pool. Whereas with SGLT2 inhibitors, definitely it would be more in patients who have established cardiovascular disease and also later in the day, where it is most likely to have an hemodynamic effect to prevent heart failure and overall cardiovascular mortality. So if you have both the agents at your disposal, probably we would use this GLP-1 oral sema earlier and the SGLT2 after the oral semaglutide for additional benefit, especially in the later stages.
Mithun, your take.
Dada, you are asking me to choose Gurkha Rasgulla and Gurkha Sandesh. I would like both together to have it on my plate. But
yeah, that would
I
be
would
the
like
best
to
one.
keep it to your purse.
That would be the best.
Definitely, patients with heart failure outsway a little bit towards SGLT2. I think that is where the swaying will happen.
And somebody with cardiac disease, no heart failure, but a little bit of more of kidney failure also. What do you would do?
GLP-1. I mean, oral sema, GLP-1. I've always been a GLP-1 fan, irrespective of the company that is endorsed it.
No. Someone with renal issues and diabetes.
So the question is, I think
No heart failure.
No heart failure is there. If the albumin creatine ratio is quite raised, then SGLT2 first and then add on the GLP-1. The question is which one will add one first before the second one. That is what you're trying to tweak out. I don't have a clear answer, Dada. But to be honest, but if the albumin creatine ratio is highly elevated,
I think which one you talked about, you would look at the criteria to whom you would not give this drug. I think I would ask him to show his bank balance.
I'll tell you the reason why I say this, and it's a true one.
Yeah, I do agree with you. I do agree with you with standpoint of data and everything.
No, the reason why I'm saying this, Dada, when I started my practicing, I went to a rural area and the person came in a badly clothed, usme chet tha, pila tha, dhoti, and I was very skeptical of even writing Vidagliptin. So I asked the relative and he said, come out, whatever the land you see belongs to this guy. So from that day, I always tell them this is the price, this is the evidence, and let them decide. From that day, I've stopped deciding for the patient for the financial way and let them tell them. So, but what I have done, and I'm sure Dada, you're doing the same, I only put people on oral repulsors before counseling them. Are you ready to be on 6 months to 1 year? If you're not, don't go on it.
Yeah, I do put in a time frame of 1 year for all GLPs.
Yeah.
If you can afford it for a year, if you do not fall out, Dr. Sharnal, although I have seen people talking about 3 months, but I do not think you reap the benefits.
No.
Arindam, the next question is perhaps for you. Yeah, the next question which has come up is for you. Somebody with acute myocardial infarction and heart failure, and you have to treat, you are releasing the patient is not fully out of heart failure, unwilling to take insulin. Your choice of anti-diabetic armamentarium may be because the diabetologist at your center is on leave at that point of time. The endocrinologist is enjoying somewhere 3,000 square feet above the sea level.
So it's very important and relevant question actually. Now, if we look at the data with SGLT2 inhibitor, the post-MI situation, the data is neutral, actually negative data. Whereas now we do have evidence with empagliflozin in the form of empristyle that we can start this molecule even during hospitalization. Yes, certain criteria needs to be fulfilled. Yes, patient needs to be off inotrope for 24 hours. There is no intravenous diuretics and the hemodynamics is reasonably stable. Then actually we can start SGLT2 empagliflozin in hospital. So nowadays we are doing it. We are doing it even in non-diabetic individuals because of the heart failure benefit. Because SGLT2 inhibitor now they are there in the heart failure algorithms. They are considered to be the fourth pillar of heart failure therapy. So from your point, yes, it is not about whether the patient actually wants to start insulin or not. Because of our own need, we are starting SGLT2 inhibitor in this kind of many patients. Now, what about GLP-1 receptor analog? Generally, as of now, I never started this molecule in this situation because of the very adverse side effects of nausea and vomiting. Patients are on multiple pills during post-MI or heart failure situation. They are on aspirin, they are on clopidogrel, ticagrelor, etc., high dose statin. So they are already having kind of nausea, vomiting, this thing. So I never tried this molecule in hospital. I always try it in a very stable situation when the patient comes to my OPD. So yes, I'm not very convinced to start them in the hospital, and there is no data as well. In acute setting, there is no data. So I'll go with conventional antidiabetic, and yes, I'll give preference to SGLT2 inhibitor, and empagliflozin will have some edge.
Same question to Dr. Sanyal. Yeah, tell me how much. Dr. Sanyal, same question to you. Are you comfortable starting a SGLT2 inhibitor in hospital? Or Mithun, take this first.
That I'm not. To be honest, I wouldn't be able to. I would like the patient to be stable at home, more metabolically and hemodynamically and everything stable before I start anybody on SGLT2. Same goes for GLP-1 as well, as Dr. Indam has said. The only reason I may prescribe on discharge is because if they have got insurance or anything, so that they can, it helps the financial load a little bit for a month's supply. But I would actually counsel them to start, at least a few days in the house when they're far more stable. Perhaps I'm not brave enough, but perhaps I would rather stay them on insulin for a little more period of time, and make them a little.
Mithun, would you like to end with that proverbial saying that fools tend to tread where angels stare not and things like that? No, beyond the jokes, and Dr. Sanyal, I think I am looking at your ceiling fan. Yeah, are you comfortable? Are you comfortable starting SGLT2 inhibitors in an acute scenario? Dr. Pandey said 2 criteria: off inotropes, 24 hours, not hemodynamically stable. What about, would you look at the creatinines? Would you at all start, if you are going to start, would you look at whether the creatinine has stabilized? Because after an acute event, we very frequently see that the creatinine keeps jumping, although the patient externally has stabilized, not on inotropes. These are scenarios perhaps which might have a little bit of a glitch for SGLT2 inhibitors. Your take?
I still don't, prefer using an SGLT2 inhibitor in a critically ill patient.
So, Dr. Pandey, you lose the election. 3-1.
So,
yeah, why we are discussing this? Because if we look at the heart failure patients,
there is one data which is coming up that at discharge you can use it if the patient is very much stable. Then you can use it. Especially there is one data which is there in heart failure patients who has a very stable heart failure. So at discharge you can use it. If the patient, probably with the caveat that the patient comes back for a follow-up within a short period of time.
so why it is important? Just I'll say a few words. Why it is important to start it in hospital? Because both the trials, heart failure, ARNI is also a big thing, paradigm trial. ARNI never was tried in hospitalized patient, acute heart failure. It was also initially tried in stable heart failure patients. Similarly, the SGLT2 inhibitor were never tried in this kind of acute setting. Why it is important to start in this acute setting? Because data shows immediately post-discharge, the initial 1 month, there is highest chance of recurrent hospitalization, and there is highest chance of initial early mortality. Now, by this time, it is quite very much evident that SGLT2 inhibitor and ARNI both are very, very favorable and fantastic molecule to treat heart failure. I'm not concerned about blood sugar. I'm talking about heart failure only. Now, from the point of heart failure, if you really want to cover this initial 1 month of post-discharge, you need to start the molecule either in hospital or very early after discharge. Now, very early after discharge, we do follow-up not before 2 weeks. In my practice, I always call them after 2 weeks. So out of this 1 month, if you lose this initial 2 weeks, then it is actually high risk. Many of the patients get readmitted for hospital, heart failure. So my take is, when the patient is dischargeable and very, very stable, if we can counsel, we can, ask the patient to stay for one more day and see whether this is doing any harm, immediate hemodynamic, any other things are going on. Then if it is well tolerated, I do continue it. And that is why all the trial, all the pharmaceutical company, all the researcher, they are also evaluating this aspect of starting it in hospital, not for the sugar perspective, but solely because of heart failure.
Thank you, Arindam. Thank you so very much. And I am holding you back from your dinner plate, perhaps a bit too long. We are 10 minutes beyond time, but we finished in time, and the discussion took us this long, and the culprit perhaps is me. And thank you for all of you who have been there. Thank you, Mithun. Thank you, Arindam. Thank you, Dr. Kota in absentia. Thank you, Dr. Sharnal, for joining in. And thank you also to Riddhish, who is on mute, and to Dr. Ajoy Biswas, who also is on mute. They refuse to be a part of this controversy, coffee or toffee. So good night to all of you.
Good night.
Thank you, everyone who has attended. Thank you for staying with us for so long. I hear from the platform people that there are still 70 people who are listening to this. Thank you, all of you, and see you again tomorrow at 4:30.
Thank you. Good night.
Good night.